about airway and intubation.
Okay, welcome to intubation. So today we're going to go through my way of doing a step-by-step orotracheal intubation. So this is oral intubation. We're not going to do nasal. We're going to talk about the step-by-step, checking the equipment, checking that everything you have is prepared. I want to go over the dexterity of how I think the best way to hold and position your hands and doing manual dexterity, because oral intubation, this is a really eye-hand motor activity. So I'm going to tell you how I like to intubate, how I've taught medics over the years, and it's generally been well received and it works for me. So there you have it. So first thing is you're checking your equipment. So your equipment is your safety. So if you've checked your equipment, and preparation is key. So I say prepare to succeed. So basically what I'd like to do is the same way every time. Intubation is a life-saving maneuver. Orally intubating somebody is going to make a difference in saving their life if you do it correctly. What gives me comfort in a very stressful situation is to know that my equipment is in the same place every time. I've checked it the same way every time. I grab the same equipment every time. You're going to find out what size blade you like and what kind of blade you like. So I'm just going to go over some basic pearls and words of wisdom for doing an intubation. So here's your airway roll. You want to have different sizes of ET tubes available, different stylets available. They're all flexible stylets, and we'll talk about that a little bit more. You have a handle and different choices of blades. There's curved blades, and then there's straight blades. So we're going to talk about it a little bit more in the video. So a straight blade is also called a what? Miller, good. And a curved blade is also called a Mac or Macintosh, okay? So I'm not here, I have no investment in either one. You need to try and practice on both. Definitely on the mannequins, practice with both. It'd be ideal if you can do intubations on live patients with both. I learned very early on that a curved Mac 4 is my go-to, and you'll hear from Ryan Wyatt, and I believe that's his as well too, and I really admire him tremendously, and he's an excellent intubator. So a lot of us in emergency medicine really like the 8. The 8. Remember I said an 8 ET tube is for a man. So a curve 4 Mac blade. And what do you see that's similar about the Mac that may be why it's ideal for intubating? Looks like a tongue, right? So perfect. So it follows the shape of the tongue, okay? It's really good for getting a big tongue out of the way. Now, a straight blade or a Miller definitely has its advantages too. I will tell you this, most anesthesiologists, a Miller, a big Miller, is their go-to blade in a difficult airway. When they come to the emergency department, they give me a big Miller, okay? So they like that because they really like to just yank the entire structures, the tongue, everything down to larynx out of their way, and a straight, long, straight Miller can really lift everything up and make the cords appear. It doesn't have the advantage of curving along the structure of the tongue, so to speak, but it does lift everything. Sorry.
Oh, you're a doctor. You're left-handed.
So just so you know, so practice with both. I like a curve 4 because I can get just about anybody intubated with a curve 4 Mac blade. Okay, a smaller mouth, I'll go for a 3. You can see the size difference. Okay. So when I'm checking my equipment, so I said you have ET tubes ready, you have stylets ready, you have a handle, okay? The way you know the handle is working, and the blade is you connect them, okay? You want to see your light, that it's what? Light is white, bright, tight connection, okay? Don't pinch your fingers here, okay? Wear gloves when you're doing this, okay? And make sure you leave the light on long enough. If you're in a dark area or whatever, make sure that, or I should say if it's bright, it's harder to see if the light is bright, but really make sure the light stays on. Sometimes the light will blink in and out, and then you have to check to see and get another blade, and if that doesn't work, then it's maybe it's the handle's fault. So you have to see if it's a blade problem or a battery problem in the handle, okay? So you check, and this is fine. So this light's staying on. So I'm good to go. So you never do this. So you've checked your light and you feel like it stayed on bright, tight, white, long enough. You never do this, okay? I don't care if you're just ready to intubate right now. You don't, that's poor technique, okay? You close it, okay? You don't leave the light on, okay? Because that's wasteful. And if it turns out to be a very difficult intubation and you're in there a long time, then you've now limited, if that light stays on for like a minute or two, you've now limited the lifespan of that bulb during your intubation. Because the worst thing is to lose your light right when you're searching for the cords, especially in a difficult intubation. So I check that I have the right blade, the right handle, the light is good, I have a good connection, I put it down. I told you I use for all men, and here I have a male mannequin, I'm going to give him an 8, okay? So if you're handed an ET tube like this, you can choose how you like to curve it. I like a gentle hockey stick, okay? That works really well for me. I think that is too angulated and too severe. And Elias, speak up anytime. Is this what you like, a curved hockey? Thank you. You must have been trained well. Okay, so I like, some people will go like straight angle out like this, a 90 degree. I think that's very pokey and I don't like that. So I like to just have it like curved so it's not in my way, and I like a right angle like that. Okay, so it's not going anywhere, okay? You'll go over in the video at least 1 centimeter to 1.5 centimeters, the tip of the stylet from the eyelet or the end of the ET tube, okay? So if I do a good 90-degree angle, there's no way that this is going to migrate through the tip of the ET tube and potentially hurt the soft tissue of their distal trachea, okay? So then there's the balloon. So I've looked at my ET tube. I like my hockey stick configuration. I like my malleable stylet. It's not going anywhere. Then I check my balloon. So if the cuff is already deflated, you get a 10 cc syringe and you get a nice tight fit and you blow it up. Now you'll see that that didn't make this tight all the way, so you have to get some more air into it and blow it up until it's taut, come out. Some ET tubes, even though they're brand new, they may have a little tiny microscopic leak in the cuff. It's called a cuff leak. So what you want to do is not just blow it up and then deflate it and say, oh, it looked good. It's like blowing up a balloon. Oh, it went all the way up, and I'll just take it down now. You want to feel it. And you basically gently pinch, and there should not be a, like feeling a balloon, where you feel a balloon and you feel like some air is coming out of it. So it should stay taut like it is here. So as such, this is perfect, okay? You're not going to really hear the leak. You're going to maybe feel it and it gets softer and not as tight, and then that means there's a microscopic leak, okay? So I'm comfortable with the amount of air that there's not a leak, and then I get my syringe decompressed, and take all the air out, okay? And like such. So you get all the air out, then fill your 10 cc all the way. So it's a stressful situation. You want to have everything ready. You don't want to have to, oh shoot, I forgot to have my syringe filled up with air. So it's like one step if you're ready to intubate and you realize you have a decompressed syringe attached to your ET tube. Then that's one step. Now you're stressed out and you're disconnecting, and so have everything ready. Or if your assistant's handing it to you, they should hand it to you as such, okay? Ready to inflate and go. To lube or not to lube, okay? So if you're going to lubricate the cuff, okay, I would recommend doing that in a patient that is dry-mouthed. Who do we have? What population do we have? Significant percentage of the year in southern Arizona. Dehydrated, right? Dehydrated patients, whether it's border crossers, dehydrated patients, we have quite a bit, okay? Their mouths are going to be dry as dry can be. I would recommend you lubricating. When you lubricate the end of an ET tube, you are not lubricating down here at the tip, okay? That's not where it needs to be. It's lubricating the cuff. Very small amount of sterile lubricant, and you just coat it lightly. It should not be glopping. It should not be dripping. It should not be big squirts of it on there, because where is that lubricant going to go? Where is that Surgilube going to go? It's going to go in the lungs, okay, and that's not appropriate, okay? So it's basically just a glistening layer so that the ET tube does not get stuck on the tongue or the soft tissue as it's migrating past the tongue, going to the cords, promised land where it wants to be. Okay, So you're going to have your BVM. This is something you're doing before you're ready to intubate. So patient should already be on non-rebreather and then put on a non-rebreather, or you go ahead and start bagging the patient, okay, depending on what the situation is. So I don't have a BVM, but you're doing good seal, good BVM respirations. So for your equipment, if you suspect that there might be a foreign body, you need to have McGill forceps available. Certainly if somebody that went into sudden respiratory distress, particularly a child that was awake and playing and all of a sudden is unconscious or in respiratory distress but not unconscious yet, you better be thinking of an acute foreign body obstruction, a toy, a piece of food, whatever. So have McGills ready in any kid with respiratory distress. It's critical. Also, if you look at a patient and they are dentally challenged, they have teeth that are loose that you think may be knocked out, I would have McGills ready, okay? So you have that ready in case a tooth accidentally gets dislodged. Okay, so as regarding, that was preparation. So stage one is preparation. So I've prepared, obviously suction is going to be hooked up either to a suction, portable suction, or for us in the emergency department, we have wall suction. I like to have everything on my right. So I have suction on my right. I have my equipment on the right that I grab for. Okay, the monitor can obviously be on either side. If I have a respiratory therapist, I'll usually have them on whether side is less crowded and such. But I have always had the suction on my right-hand side. So if I'm intubating in a stressful environment, on the floor, on a bed, on the ground, wherever, in the cafeteria, that I always know that if I had a portable suction, they would put it on the right-hand side, and that's where I'm used to having it. So no matter what stress I'm in, I know where my equipment is. So have everything ready. So I'm going to intubate him with a Curve 4 Mac blade and my 80 ET tube right here. So I have everything ready. So when you're ready, and I'm going to do it without the mannequin first so you can see my techniques. I want you, if you're standing and doing your first intubation in the emergency department, or if you're in the field on the ground with the patient, I want you to think that their head is here and you're standing at the head, and think that you want your angle of how you're holding your hand on the blade, your hand on the handle, that you want this to be in a 45-degree direction away into the world, okay? Your world could be in the emergency department in one of our ER rooms. Your world could be in the back of a truck. Your world could be in the bedroom of the patient's house when they're found on the ground next to the bed, unconscious, unresponsive. But I want you to think 45-degree direction of your thumb is part of the handle, and it's going 45-degree direction away from you. Because if you do that, you're going to find the cords, and you're not going to rock back and injure the teeth. And it's not so much that I don't want teeth getting injured. It's the fact that if you're injuring the teeth, that means you're rocking back and you're not finding the cords. So it's improper technique and not getting you where you need to be, and the teeth are the victims or the byproduct of you not getting where you need to be, okay? So when you're ready, when you have everything ready, it is best to try to do intubation with both hands, okay? In the beginning, you might be stressed and you might want to manipulate the head and have somebody hand you the ET tube. I think that's fine, okay? If you're intubating with me, I will definitely hand you the ET tube. I will definitely help you, okay? So some people, it takes a while before they're ready to manipulate the head, open up the mouth, and do all that while they're holding the ET tube at the same time. And I get that. That's totally fine. Okay, so when you have the head, obviously we talked about before, you're going to look at what makes a difficult anatomy for the airway. You're going to do what you can do to try to open the airway and improve your chances of success, okay? So if it's a non-trauma patient, you're going to do what to their head and their jaw? You're going to do head tilt, chin lift, okay? And you're going to find that especially in a patient that's decreased level of consciousness or certainly unconscious, where you pull their jaw, they're really going to stay that way, okay? So, so you pull out their jaw as much as they can. And then I like scissor opening, of course, with gloves, okay? So anytime you're touching somebody's mouth, you're obviously wearing gloves, and you have to be careful if you're not comfortable touching the inside of a patient's teeth. But a scissor opening really does help open their mouth, okay? So scissor opening, you're crossing your fingers, and it's really something you kind of have to see, or you can do it that way, but you really get more bang by just opening with scissors, or you can actually just pull down their jaw. And like I said, generally it will stay that way, okay? You're first going to, of course, remove their dentures. Anything that comes out easily, you're never going to struggle and try to rip out a bridge or anything like that because you think you have to get everything out before you orally intubate. If it comes easily, you take it out. If it does not, leave it in, okay? And be very careful. Some of these will cost like thousands of dollars, so you do not want to hurt their bridge. So you've looked and you've opened their mouth, you've suctioned them as appropriately, not aggressively, but suctioned so that you have a nice, clean, dry, pristine mouth to go into, okay? Recognizing if they have a big tongue, okay? So the technique is this. So when you're ready to go in, that's when you turn your light on, okay? You're ready to go in. The head is here. Everybody does it the same way. It's uniform, that you hold the laryngoscope with your left hand, the tube with the right hand, whether you're right-handed or left-handed. Do not hold like this, okay? You've lost your dexterity if you're holding too much on the blade. Definitely don't do this, and I see a lot of people do this in the beginning. They think their whole hand needs to be on the handle. It's really right there in the middle. This is like the crotch of the laryngoscope blade and handle. I like to have my hands right there, and I make my thumb part of the handle. So this is all one unit, and this is so helpful if you're intubating in the back of the truck without me even being in the back of the truck. I know this is the way to do it, because if the truck is moving, you're going fast, you're going code 3. If you are moving, your whole hand and the blade moves as a unit. If you're like this, you're going to knock it inside their mouth and damage teeth and damage the mouth, because you're jerking with your wrist and your hand is causing damage inside because you don't have good control over the blade inside the mouth. So best control is if somebody knocks me, very little movement, because I don't have a vice grip, but I have a secure grip because I'm gripping at the union of the handle and the blade. Does that make sense? Okay. So think of it this way, that you are, as a unit, you are holding it at the crotch of the blade and handle, nice and secure. And when you go into the mouth, after you've done your scissor opening, mouth should stay open, you open the right corner of the mouth and you sweep to the middle. Almost always, every paramedic on their first attempt to intubate goes straight into the mouth, okay? They're excited, they're stressed, it's adrenaline situation, and they think, blade needs to go into the tongue, okay? But actually what's gonna happen? The tongue's gonna flop right into your view. It's gonna flop from the right or to the left, right in your view, and block your view of the cords. So you have to start in the right corner of the mouth, and this is the same with the Miller as well. You need to do it with the Miller as well. Start in the right corner of the mouth and sweep to the middle, and remind yourself that it's a 45-degree direction away, okay? So there should never be any rocking back of your wrist. If you do that, you're going to hear the click on the mannequin. You're going to hear you're hitting the teeth in the field. I'm going to tell you, I'm going to be looking right in the mouth and say, on the teeth, you're on the teeth, you're on, get off the teeth, get off the teeth, because you're looking for the cords. Whoever your supervisor is seeing where you are oriented in the mouth, okay? And you have to be mindful of where you are in the mouth. On babies and toddlers, they won't have teeth. So when you rock back, you're going to injure what? Their gums, and you can cut and tear their gums, okay? So there's never rocking back of the wrist. You keep your forearm and your all the way through your wrist is as a unit. Keep it locked. Doesn't mean you're like in a vice grip, but you really keep it at a 45-degree angle, and you don't have to have strong forearm strength. As you can see, I don't have well-developed forearm strength, but I'm a really good intubator because I know not to do this, and I know to keep this all solid as one unit. Question?
So why do you always hold the blade in the left hand regardless of dominance?
It's just, it's a standard that's just accepted across emergency medicine and anesthesia. So also, good point, that do you see here, you asked the question, the laryngoscope blade is so that, do you see this? So that the laryngoscope blade is structured so that the ET tube is sliding down the middle. So it has to approach from the right to go in as such. So it's the way the laryngoscope blades are designated as well. So that's really the main reason. So by conformity is why it's that way. So right corner of the mouth, okay? So the blade right corner of the mouth, you almost always have to go in a little bit further. and you are going to do motions that are going further down, not rocking back, okay, and never jabbing, okay? And it's a little easier to show on a mannequin than my hand suspended in midair. The key thing is that the ET tube follows what you just did with the laryngoscope blade. Corner of the mouth and advance it. If you go straight in like this, you've now blocked your hard-fought view of the cords. So again, corner of the right side of the mouth, sweep it right into view of the cords. Do not advance the ET tube unless you see the cords. You might not see all of the view of the cords. If you see limited, you're going to see the posterior, okay? Because the difficult airways are more anterior. And that's when you have to rely on somebody giving you more crike pressure if you don't see a full view of the cords. So you go in, and you never, ever, ever take your view off the cords. So you don't need to talk to the driver. You don't need to talk to somebody and say, hey, you have suction ready for me, right? Oh, crap, I just lost my view of the cords. Okay, or say you drop this. Oh, crap, I just lost my view of the cords. Somebody's there to help you. Don't look for the suction. That's why I see people make mistakes. They go looking for suction, they drop their ET tube, or they didn't want to hold it. They wanted to open the mouth a little bit more. I can't find it. Oh, here it is. Okay. Or be a good assistant. I've had so many people over the years hand me an ET tube like this. So don't do that. Hand it to them, and their hand is out like this, right in like that. Go. So hand it to them the right way, okay? Everybody knows, hand it to me the right way. Hand me a McGill the right way. I don't need to look away if you hand it to me the right way. So you go in, and you never take your eyes off the cords. No matter the ambulance is moving, you don't look away. And it is uncomfortable, okay? If you can't get the intubation right away, you still have to keep your forearm, wrist, and hand in a unit locked and loaded like that. You just can't, I'm getting tired and want to relax your wrist. You can't do that or you will not find the cords and you'll hurt their mouth or the teeth. So you put it in, and hopefully you have an assistant, okay, that is going to simultaneously take the stylet out. You can back out, and that's another mistake I see. You need to back out the laryngoscope blade in the same angle you went in. So you went in nice and gently. You started at the right and swept to the middle. You back it out gently. You don't have to back it out to the right, but some people just pull it out, and they knock the teeth out on the way out. That's not right. So you back it out and come out gently, okay? Because everybody just wants to know if the tube's in the cords. Oh, I got to see the end-tidal CO2. Oh, just come out real quickly, and they don't think, and they're hurting the patient. So you take it out gently. You're securing. This is hard, obviously, to do all by myself. But you have the ET tube in, and somebody's taking the stylet out, holding the ET tube in place. This one's really rigid. And at the same time, inflating the cuff. You might need to do it twice and inflate some more air in the cuff. And end-tidal CO2 should immediately be available. Easy cap, really nice and fast. What's the color change mean? What's good, what's bad? Gold is good, purple poor. Okay, so yellow or gold is good. How many breaths do you need to have reliable, good color change? How many? At least 3 to 5 breaths. It really should be at least 5. Okay, the more the better, in other words. Okay, so what was I also going to say? So the securing in the field, you're going to have marketed tube securing devices. In the ER, we have respiratory therapy do it with taping the tube, and you can watch them do that. So means of confirming that you are intubating the patient correctly, that there's good ET tube placement in the trachea, not in the esophagus. What's the number one most accurate way that you can confirm your ET tube is in the trachea? Capnography. Okay, if you don't have a capnographer, easy cap is just fine too. Okay, capnography is better because it's measured electronic data rather than an easy cap. Easy caps can be old. They could have malfunctioning from the manufacturer. The chemical could be old or desiccated and not change color. If you think you did an excellent intubation and you saw the ET tube go through the cords and your easy cap is reading purple, I would suggest you get another easy cap. Okay, break up another bag, it's fine. in general, I'm going to tell you this. Do not take out an ET tube that you witnessed it go through the cords and you did not have any suspicion it was dislodged. You can put a tube through the cords and then all of a sudden your ambulance takes a big turn and you hadn't had it secured yet and your hand pulled back and you pulled the ET tube back. Or unfortunately, I see the medics when they're transferring the patient from the ambulance gurney to our stretcher in the emergency department, that tubes get dislodged then, okay? They're like, who's got the tube? Oh, I've got the tube. And somebody grabs the tube as the patient's being transported over to the bed. And all of a sudden, then the tube's like hanging out this much. And I'm like, oh my God, nobody secured the tube, okay? So it's patient movement or your hand moving when you reached for something. You had a hand on the ET tube, but you reached for something and you didn't realize that part of your body stretched when you reached for something in the truck. And so that's how tubes, it's not meant to be. It wasn't intentional most of the time, but it happens that tubes get dislodged. And they maybe just get dislodged where the balloon goes just right above the cords, but or it goes higher up in the oral pharynx, and that's not where we want it to be, okay? So we want the balloon past the cords, all right? So fogging of the ET tube is good to note and important medically legally that you see fogging of the ET tube, okay? Breath sounds bilaterally and equally over both lung fields you need to document. No breath sounds heard where? Over the stomach or epigastrium, right? Okay? Those are all important, but the most accurate medical legal definition of a secured endotracheal tube is end-tidal CO2 capnography, better than easy cap, okay?
Quick question. So you talked about the order of, you get it in, you pass the cords, and then you secure.
Yes.
Can you touch on for them when they let go of the tube?
Right. So it's hard with me by myself, but it's kind of all. Why don't you come up here with me? So, so when you are inflating, there's three things that need to happen kind of at once, because if you have help, you can really do it all at once. So you've got the blade in, you've got the ET tube through the cords. You can have, if you're by yourself, a lot of people hold two, and Ryan will show you some techniques because he's by himself, obviously, a lot in the helicopter, so that you blow it up and then you get rid of that and you can hold them both together. So you definitely need the balloon up. Okay, you're not going to be able to feel it when it's in, but you need the balloon up, and you do not take the stylet out until the balloon is up all the way. So always think, I see the cords, I blow up the balloon, and then the rest kind of happens at the same time, that the stylet comes out, and you want to hold that like that. You want to hold this stylet. I mean, the right here, like that, yes, yeah. Ma'am. So I'm in, and the ET tube is in, and I blew up the balloon. So coming out and taking the stylet out, it's pretty much at the same time. I certainly usually come out first because it's so crowded in there and there's so many hands in there. So it helps to get the laryngoscope handle out first. So I come out, I close this off, and then usually, like I said, I have a ton of help, but somebody holds the ET tube and takes the stylet out, okay? So that actually kind of can happen simultaneously. But what can't happen, this has to go first, okay? So you think about it, if you're pulling out a stylet out of an ET tube that you don't have the balloon up, what can happen? You pull the tube out on top of the cords, okay? And then you realize it, then you blow up the balloon, and then the balloon might be above the cords or at the level of cords, and it'll hurt the cords if you blow up in the. So just be gentle getting the stylet out. It usually comes out pretty readily. And another trick of the trade is when you're holding an ET tube, and I'll just have you be ready for my assistant, you help me with the mannequin here, that it is very important to watch where your hands are on the patient. You need to be respectful, and you need to not hurt the patient. You don't mean to, but I don't want to see any of this. So when you're getting ready to intubate the patient, I don't want to see any of this. Like, okay, you ready? Everything ready? And you're just, like, this is not a table, okay? Their faces are not, and you'd be surprised, okay? Their face is not a table. It's not a landing place for your hands or your tools or your instruments and stuff like that. So what you can do is you can have your hands around their face and definitely be ready, okay? And let me get my hockey stick back again. We'll do it on the main mannequin here. And so you can definitely be ready. So I've been bagging, the BVM comes off. I'm not a trauma patient here, so I'm going to really try to hold the head down. And I think I'm going to have to actually have you hold it. Devin said you have to hold that. So I have really good head position. I'm ready to go. I've got all my equipment over here. I've like everything I have over here. So I do my scissor opening with my hands. And I see medics in the field that they'll tell me they'll do this or whatever. I think that's okay. I just don't want like, hey, when are we going to intubate? Elbows up on top of their eyes or on their face or whatnot. So it's scissor opening, okay, inspecting the mouth, do a last minute suction, 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 again, so you have a dry, pristine field. So steps are scissor opening, light on, right corner of the mouth, sweep to the middle, nice grip on the crotch of the handle. My thumb is part of the blade. I might need to go like this a little bit, and I look, and it's totally fine to have your forehead on their face like this, because it's really, as long as you're not directing pressure to their eyes. So, there we go. So, corner of the mouth, midline, and it's in. So I say to my assistant, balloon up, coming out, gently. I'd get the light off. And this is what I want to teach you. Do not hold the ET tube up high here, because all of a sudden your driver comes to a complete stop. And you go forward and you pull the ET tube out, or you fall backwards and you pull the ET tube out. Even though the balloon is up, let me just tell you, that balloon is not much of an anchor, okay? It's going to go wherever that hand is that's holding the ET tube. Trust me on this, okay? So you will have success about not dislodging a tube if you keep your hands pinched on the ET tube at the level of their mouth. And it's perfectly fine to have your hands resting like this. So a lot of medics, a lot of doctors, a lot of anesthesia, they'll rest their hands like this the whole time they're talking. They'll intubate and they'll talk to the surgeon, and their hands are like this the whole time. So pinch on the face is fine, but just watch your hands are not on their eyes or on their nose, that kind of thing. So pinch, and then you ask your assistant, can you get the stylet out, please? Okay. See, now this one's really stuck. I need two hands on this one. It's not going to be like that in the real life, okay? But you got to watch what you're doing, and people sometimes really get very lax about holding the ET tube, and it's a shame when it gets dislodged because you just did all that work, okay? So then you should immediately have the easy cap already hooked to a BVM, so it is seamless that you have hooked this on, and this should be attached to the BVM. So you put it on, and how many breaths? At least 3 to 5, okay? And you want to see fogging of the ET tube. You want to see chest wall rise and fall equally. No breath sounds over the stomach or epigastrium. You want to see yellow color change. And you want to inspect to make sure you didn't hurt the patient, okay? I didn't click the teeth. You didn't hear any clicking, right? So your assistant can also be looking to make sure, I don't know if you looked to see how far away I was from the teeth, but I was not anywhere near the teeth. Glad I passed. So look to see, because sometimes, unfortunately, I have hit the teeth, okay? I've hit the teeth in patients I have very small mouth opening. And it's a critical situation. They don't need to be criked just because they have a small mouth. It's just you have to, I just have not a lot of movement in the mouth, and I just have to make sure I get it, or else I have to call anesthesia or do it. Glide scope actually helps reduce that problem because you don't need a lot of mouth opening with the glide scope. So really try to keep hands down low, okay? No jerking, jabbing. So I don't want to see any of this. I can't see the cords. I can't see. And you'll be surprised that it's not really that rough, but I do see kind of jabbing, all right? So when you go in, you don't see it. Well, I guess I have to take this out. Can you take the blue air out? So if you don't find it, you go in there, and you almost don't ever find it. Let me just get this out. Almost always your first attempt, like this first attempt, I'm at the base of the cords, and then I go a little bit further in, okay? So migrate it down and 45-degree angle away, and think I need to go deeper and more interior, but almost always crike pressure will help you find the cords. So RT or your assistant in the truck say, I need more crike pressure, okay? And sometimes even they call it burp. So burp actually works really well. It's backward, upward, rightward, posterior, or whatever. So just putting a little upward pressure can make the cords pop into view. So anesthesia likes the burp. So anyway, and then you find the cords, okay? Suction when you need to. Don't think you can only suction before or after. There's plenty of times I'm in there and have a view and then I lose it because of pulmonary edema fluid or vomit. So suction, but again, never take your eyes off the cord. Suction, okay, tube, okay? So don't take your eyes off. Suction if you need to, if you're losing your view. Somebody tells you the sats are dropping, get out, okay? You cannot let your ego get in the way. It's very frustrating, especially you think, oh, the doc's only gonna let me have one chance. And we say, the sats are 90. Okay, and I tell you, keep going. And then I say, the sats are 84. Okay, you need to come out. You need to come out, okay? When the sats are dropping, patient's not doing well, it's taking too long to intubate, or the patient's deteriorating, or both, okay? So if somebody tells you the sats are dropping or they're developing a new arrhythmia, you need to be mindful about that. You need to park your ego, and you need to get out and let somebody more experienced do it, okay? Questions?
Do you have any recommendations for when they verbalize as they're doing, what they're seeing?
I think that's fine. For me, usually it's, what do you see? What do you see? Do you see the cords? Do you see the cords? Do you see the cord? Because I think it's really, it's vomit, or it's blood, or it's fluid, or it's foreign body, or pulmonary edema fluid, that there's something above, or they just usually just don't see the cords right away. And a lot of it is because a lot of patients have to have their head really manipulated good. And we have a trick that anesthesia and ER doctors do is we roll up a towel and put it between their shoulder blades, and that actually makes their cords pop out. So we'll do some tricks to make their cords come out. So when I can't see the cords, there's things that we do in the ER. So I need to know if you can't find the cords, because maybe I can't either. Maybe I think it's an easy intubation. You get in there and you can't find the cords, and then I go in there and I look and I'm like, crap, I can't find the cords either. Okay, let's bag them up. Let's roll them over. Let's put a towel between their shoulder blades. And a lot of times that helps, okay? This is for doing a direct laryngoscopy. Like I said, the glide scope is really making this almost obsolete, okay? Because the glide scope really finds the cords for you. The only time the glide scope lets you down, difficult airways, bloody, fluid-filled airways, because you just can't, because you're depending on a video. So if your view is blocked by fluids coming up, you have to suction as fast as you can see on that video. It's often better to be actually in there yourself doing a direct laryngoscopy when there's a fluid-filled field, shall we say. Most patients are going to be between 20 to 24 centimeters, okay? So that's really important, and I'm sorry I passed by that. So you want to say how many, you want to, for documentation purposes, what size tube and where the tube is at the teeth or at the gums or at the lips. You can make a choice. If they have teeth, we generally, by tradition, say 20 centimeters at the teeth with an 8.0 ET tube, no complications, okay? Or if they don't have teeth, then you say at the gums or at the lips. But teeth and gums are a little bit more accurate because the lips obviously kind of move, you know what I'm saying? So yeah, that's the standard. So if you go and see your partner did intubation and you see this much, you see it like really buried, see just the cap of the ET tube, so to speak, at the level of the mouth, then you know what? That it's what? Right main stemmed, okay? So that's also important. So any intubation, it's your job as a medic. It's really not good care if you have not auscultated that patient before you've intubated him. You need to listen to the patient's lungs before you intubate, because you have to know what they are before, so you know what they are after you've done an intervention. And there's not much bigger interventions than intubating the patient other than cracking them, putting a chest tube in, or cutting open their chest. Or, you know, so that's a major intervention in the patient. So you want to know what their lungs were like before you intubated them, and therefore what afterwards, okay? Because if their lungs were perfectly equal bilaterally, and then it was your first intubation, and you don't hear good lung fields over the left, or just a bit diminished, but they're good on the right, you've probably right main stemmed the patient, okay? And like I said, it's not the end of the world, but it's not perfect, and we want to just make it a little bit more perfect.
So as soon as you pass the cords, then that's when you pretty much know that you're in, so you just pass the cords.
Very good question. Thank you. I didn't go over that either. So as soon as the ET tube, you see it, go past the cords, stop. And that will prevent you from right main stemming the patient. Because I think that's what happens. A lot of people are so excited or stressed. They see the cuff go past the cords, but they think they've got to keep going. And that's not. You just go past the cords. But making sure it's past the cords. You don't, it's not like just a few millimeters. Like, get it past the cords. But don't go further than that. And a lot of people just shove, and then it's going to be right main stem. So it's a very good point. So as soon as the cuff is past the cords, you're good. And if you're pulling up to the hospital, the first thing we're going to do, obviously checking ABCs and this patient's stable, we're going to get a chest x-ray. Anybody that rolls in intubated, we're already calling respiratory therapy, and we're calling x-ray to get a portable chest x-ray. And the doctor sees it within 10 minutes. So we'll know right away if the patient's right main stemmed. So really good points. Thank you.
If you suspect the right main stem and you back up ET tube, should you deflate the cuff and pull out, or
Okay.
should you?
Yeah, so in the field, I don't prefer that you as students, that I don't want you manipulating the tube in the field, okay? So that needs to be done by a senior medic, and in the hospital, you're gonna only do it under the supervision of a physician, okay? Because it can be backed out too far. So when we see it right main stemmed on the chest x-ray, or somebody from the field brings in a patient and I see that this is buried to here, I'm going to pull the ET tube back out some more because I know it's right main stemmed. Whether I hear decreased breath sounds or not, the tube should not be buried like that, okay? So, so it is always deflated first. So that balloon has to be deflated because you're pulling back. So you don't do any manipulations with the tube forward or backward or anteriorly or posteriorly without having the cuff deflated, okay? Or else you could hurt the inner linings of the trachea and hurt the tracheal rings. So it has to be completely deflated, and then you manipulate the tube. And the respiratory therapists in the hospital, they're the ones doing it. The physicians can do it, but usually we'll say to RT, pull back the tube 2 centimeters. It's right main stemmed, or it's at the carina, pull it back 2 more centimeters. So does anybody know the perfect place for ET tube placement on a chest x-ray? It's about 2 to 3 centimeters above the carina in the distal trachea. Okay, and that gives excellent adequate oxygenation to both right and left main stem bronchi.
Exactly where do you want to seat the tip of the Mac blade when you go in?
Okay, so you want to, as you're going from right to the middle of the tongue and sweeping, you want the tip to go down straight midline as far as you can go to reach the cords. So you're hoping the tip, whether it's the Mac blade or the Miller blade, to reach just to the level of the cords. It's just not long enough usually to go past or through the cords. So it's designed for a length like this for a reason, for adults. And so the tip is really going to be just, and there's a video that shows it better, or actually it's on a cadaver that we'll get to this afternoon, that the tip is really going to be just above the level of the cords. So you have a view of the cords hopefully staying open because the patient is unconscious or because you've paralyzed them. And so that the cords are right below the tip of your blade, and you can see it with your hand locked. And you might get tired. Like I said, I don't have much forearm musculature, but I don't care if I get tired, and I can hold my forearm like this for a long time if I have to do multiple intubations and I don't have any help. If anesthesia in the middle of the night is doing a case and I'm the only one that can intubate in the hospital, I've got to be the only one that can intubate in the hospital, okay? Or cric them. But I can't let myself get tired, because when you get tired, you get muscular fasciculations and that kind of thing. You can't let yourself do that. So you hold it locked in for as many times as you need to intubate the patient, and that you make sure that you go from the right corner of the mouth toward the middle, and that you don't obstruct your view until you get the tip of the ET tube just at the level of the cords, so you can see the tip passing through the cords, and that has to be your documentation. I visualize the ET tube passing through the cords. I say that on every patient, okay? Or if I have a poor view, then I'll be honest, and I say I had a poor view of the cords, limited view, only the posterior cords, but I slid the ET tube past the posterior view that I had of the cords. So that will stand up in court. Question?
So in the pre-hospital setting, if you get a visualization of the cords and they're closed, what do you do from there?
You're not going to intubate through closed cords. So you tell your supervisor, I can't pass the tube, the cords are closed. So it's usually going to be because the patient's breathing or they're in spasmodic closure. So you're seeing them when they're breathing, they just haven't opened up their cords yet. Often if you can wait a few seconds, if they're waking up or they're awake, then the cords will open back up. But generally, you're going to be only intubating patients that are unconscious or they're done through RSI from somebody else that is trained in RSI. So generally that'll be in the emergency department more than it would be in the field.
What about anaphylaxis and swelling?
Okay, so in anaphylaxis and swelling, you're gonna, and we did talk about that. So what size tube are you guys gonna grab for anaphylaxis? Okay, you're gonna get a smaller one. Okay, so a woman you could get a 5 and a man you get a 6. So 2 sizes down, or half size, or a couple half sizes. So, and you have to be, in anaphylaxis, you really get 1 shot. Okay, like I told you about my trauma patient with the laryngeal fracture, that the trauma surgeon was standing over and said, you have 1 shot, like meaning he really didn't even want me to try. Little confidence. So you have 1 shot in trauma to the neck, you have 1 shot in anaphylaxis. Smoke inhalations, those have also been one of my most difficult intubations, where they're really swollen and soot all the way down to their cords. I've had to dig out soot I've dug out soot with the McGill forceps. I've made a tunnel and just burrowed and made a quick tunnel and took soot out and then intubated through that. Of course, I could have criked them, but I was pretty fast, so I got it that way. So there's different ways to do that. Certainly going straight to a crike on that would be fine too. So be mindful of swelling, be mindful that there's intubations that you're only going to get 1 attempt, and the most senior person should do it. Any other questions? No? Thank you. Thank you, Devin. Thank you.
So here's a patient I'm attempting to ventilate with an oropharyngeal airway in place. Unfortunately, there doesn't appear to be good chest rise. And using my airway algorithm, I'm going to escalate to an I-gel airway. Okay, so I'm going to choose an appropriately sized I-gel. I've got a size 4 here. The patient appears to be approximately 70 kilograms. So I'm going to take my I-gel, checking its sterile packet, ready to use and it's serviceable. I'm going to put some water-based lubricant in a divot there. Lubricating the back, sides and tip of the I-gel. Be careful not to get any in the lumen itself. I'm going to remove the OP, tilt back the head, consider the need for suction, insert the I-gel to meet definitive resistance. That's going to be capnography, catheter mount, and finally bag valve mask onto the patient there. I'm going to attempt to ventilate. Okay, so considering I can see good chest rise there, I'm seeing colour change on the capnography. I'm going to attempt to rotate as well. Ventilate once every 6 seconds. So I can hear good bilateral air entry. I'm going to attempt to secure this airway in place. Again, ventilating approximately once every 6 seconds. Now the airway's secure, I'm just going to re-auscultate. I'm still getting capnography change there, or colour change on the capnometer. And I've still got bilateral air entry. I'm just going to continue to ventilate the patient.
It's a real informal lecture, so anytime y'all have questions during this, just stop me. We'll talk about it. We'll shoot the breeze, whatever. I don't think, like Nick says, I'm a professional at it. I've done it a time or two. And it sounds like a scary process when you do it, and sometimes it can be. When you do it, make sure you have a little extra deodorant on, because actually you're taking somebody's ability to breathe away when they may have been breathing fine. But, these could be some difficult airway times, and this is not a difficult airway class. That's a whole another lecture. We'll talk about some backup airways, and I got a few here we'll go over toward the end of the class. But once you take somebody's respiratory drive away, I mean, it's gone. You know, we got ways to breathe for them by bagging them or whatever, but it's not something you want to do. You want to get this tube on the first, second try, and if you don't get it, then it just goes downhill from there. So again, I'm Brent Wilson. Like Nick said, I work for Lifesaver, been a flight nurse with them. Actually, I started as a paramedic, went to school here, so I was in the same chair that you guys were. Finished paramedic school in 2002. Worked as a paramedic for East Alabama for about 3 years while going to nursing school. Got out of nursing school in 2005 from here. Started flying for Lifesaver as a paramedic in 2005, worked in the ER some. Did a little time at Children's Hospital in Atlanta, and then moved back here. But all the time I was still working for Lifesaver. In about, 2007, first 2008 I started flying as a flight nurse. 2009 took over as the little base manager position, but I didn't tell anything but listen to complaining and doing the time and payroll. So it's not all it cracks up to be. But it is a fun job. We like it. We do see bad stuff. Everybody will tell. It's like, oh man, y'all see all kinds of bad stuff. Well, actually, you guys are the ones that see the bad stuff. We don't get the calls of the ones that are already dead and mangled and tangled up. So you guys are the one that sees the bad stuff. We see the bad stuff that's still alive. You guys should see the worst of the worst. And been there too, saw some bad stuff. So anytime, feel free to stop me. If you don't understand something, let me know. We'll go over it. And this is a slide that's already built. I modified it a little bit. Kind of based it on the state protocols. We had a modified RSI that we used to use, but this is actually based on the state protocols and what we use now. So we'll get started here. Come on in. So what we want to do with this is to establish and maintain a patent airway and patient requiring an intubation through the meds that we have to give them to help. So times that you want to do an RSI, anybody think of something right offhand? We need to take somebody's respiratory drive away and place it and give them an ET tube or something. Somebody just named something.
Major trauma.
Trauma, burns. The burns they're iffy though. We have a talk with Dr. Melton, who's our medical director. She's I guess the head trauma surgeon at UAB. They call her Scary Sherry sometimes because she's so mean, but I kind of suck up to her and she lets us do whatever. But we bring these patients in and we kind of ask them, what would you do, things like that. So burns are a different story, but it can be a time you want to RSI somebody. People that's had strokes, vomiting, things like that we're not going to be able to control the airways. And what we got to think about, you guys are in the truck, you have a little more room. We're in the helicopter, and we don't like to intubate in the helicopter, but we will, just because it's hard to verify because you can't hear and it's a small space. So we'll go ahead and we'll RSI them before we lift off or at the scene. And we don't RSI everybody. We may do 1 or 2 a month, so if that. So we don't do it a lot. And sometimes we'll go months without intubating anybody, and then we may do 5 a month. So when somebody's got an intact gag reflex, of course, if they're totally unresponsive, you can pass the laryngoscope in their mouth, throw a tube in. They don't need RSI. You can always attempt it, and if they don't need it, intubate them. That's less drugs that you have to give. They've got some hemodynamic properties. You want to take the blood pressure and stuff away, even though the ones we use right now don't really affect that much. So if they don't need the meds, don't give it to them. If they're combative, and again, I base all this around flying. We don't want anybody kicking the pilot, we don't want anybody opening the door, kicking the window out when we're, 2,000 feet off the ground, and, that's kind of a bad situation. We just don't have the room to restrain them, so we'll use chemical restraints. We hardly ever use physical restraints on our patients. GCS less than 8, they say intubate, but that's also a fine line when you get out in the field. That's kind of the book, and I'm going to teach a little bit of the field side too, but always for tests, make sure you answer by the book. If somebody's breathing okay and they're doing well and they're keeping their sats up, you don't really want to take their respiratory drive away, especially if they're going to be a difficult airway, and that's what we'll kind of look at during this class. If you think they may crash en route, you may want to go ahead and RSI them if you got extended time to the hospital. I mean, if we were here, we were going to East Alabama, we could bag them that far for a few minutes, but if we had a 20, 30-minute time, we probably want to RSI them. And RSI does take some time, and especially if you're not familiar with it, you got to get all your stuff set up, and we'll go through that too. So it does take a little bit of time. So in the meantime, you can be kind of on the way to the hospital. Trismus, people that's clenched down, trauma. If they vomit, their teeth are clenched down, so they don't have anywhere to go but in their lungs, so they aspirate it. So we get some sucks, and that'll usually relax them. Get a tube down there. Laryngospasms, you see those every once in a while. Seizure activity that won't break will be an indication for it. Contraindications, this is the most important. So inability to ventilate the patient with a BVM. So what if we don't get this tube? What are we going to do? How are we going to ventilate them for the 5-7 minutes that it takes for the sucks to wear off? I mean, that'll kill somebody right there. Have a noxic brain injury at least. Beards, large obese people, things like that. If we're not going to be able to ventilate them well, massive facial trauma, if we can't get a good seal on their face, and they're doing okay with their breathing, we really don't want to take their airway away from them. We do, or can do, needle and surgical cracks. I've never done one. I think there's only been one or two in the state of Alabama, like in a couple of years. So it's not something we do. We know how to do it. Would I be a little shaky when I was doing it? Yeah, because I've never done it. I've practiced on it, but never done it. And the ability to perform intubation effectively and safely without RSI medication. So again, if you don't need it, you don't need RSI. Things to look for, and a lot of this stuff is based on like anesthesiology, CRNAs. If you ever been with somebody that's going back for surgery, whatever, you get an anesthesiologist come around. But trauma again, these people are unresponsive, they're combative. They're not going to be able to open their mouth and look at it and see. But if you're getting ready to RSI somebody, that's what you would want to do. Usually we have to call for orders. We call Dr. Melton and Dr. Kirby at UAB, and sometimes they'll ask of this. And they were really asking a lot when we first started RSIing people, and we had to get orders for it. Again, we used to use a modified version. We would give Tomidate and Versed. That would usually relax them enough that we could intubate, but sometimes it really wouldn't. They would cough on you, and they would have a laryngospasm. You could see the tube. You just couldn't get that tube in there. You just ram it in there. But once we started using sucks and Tomidate, our intubation percentage success has gone up because they're relaxed. You just slide that tube in there. They're not fighting. They're not coughing like they would with a Tomidate and Versed, which if you don't get it, the Tomidate and Versed will wear off. They'll still breathe. So a lot of times they would ask for this.
So is the the class 3 and 4 are they going to be like contraindications?
Not contraindications. You just know that you better have your crap together when you start to intubate. Oh, hit that. This is probably pictures a few slides ahead of what it should be. So you got the mountain padding, the classes, and then you go to grades. So, and this is when you introduce the laryngoscope. This is what you want to see a 1. Smart board for dumb people. Doesn't work out. So you want to see that 1, but that's bad. That's okay because you can see something. When you get to a grade 4 airway, you're just praying and hoping and pushing. And I'll jump ahead a little bit. Anybody ever seen one of these? Bougie. Lifesavers. That's what they are. And we will, just because somebody's thin, and you may have learned that obese people don't usually have very good airways and they're hard. Well, they are hard, but I've seen thin people that are worse than that. For some people, they're real anterior, they'll say. So if you can even see that, say that's a grade 3 right there, that's all you want to see is just that little hole right there. You can take this thing, usually it's fairly flexible. You can get it right where you need to be, you stick that in, and then hold it once you see it go past through the vocal cords. Sometimes you can feel the rings in the trachea, intubated 1. The day before Friday, you could feel the rings in the trachea as it was going down. I didn't know if it was in there or not, but I could feel that sometimes your partner, if they're holding crite pressure, they can feel you kind of bumping around. You just take your ET tube, slide over that, keep a laryngoscope in their mouth, slide over it, watch it go through. That way you kind of know your depth. So these are lifesavers. We'll break these out on almost every patient. They're maybe $10, $15 a piece. I don't know. So, but they do help. So make sure you always have that ready.
So when the meds wear off, do the respiratory drive come back?
It will. But if you don't have a way to ventilate them for 5, 7, 10 minutes on sometimes, some people eat through it pretty fast. Yeah, I mean, what are you going to do? So, but they do wear off. But as we get into the lecture, once we paralyze them, I mean, they were kind of awake a little bit before we gave them the meds. We gave them sucks, which is a short acting, which we'll get to. But then once that sucks wears off in about 5 minutes and Tomidate wears off in 5 minutes, now they're intubated and pissed off. So they're going to be pulling, they're going to be crashing. So we'll give them something else a little bit stronger. We'll get to that. Again, on the patient assessment, this is a 3-3-2 rule right there. 3 fingers in the mouth. 3 fingers from the chin to the neck and 2 fingers from the mandible to the, I got the thyroid notch, which is actually the higher up thyroid bone. Okay, everybody do it. 3 fingers in your mouth. I had to count my fingers too. Try. You got good. If you get it in there, that's what you want to see on people. If you can get 3 fingers in the mouth, I mean, they can't. Who hungry? It's going to be hard to get in there and see. So look at that before you do it. 3 fingers in the mouth. We want 3 fingers from the neck there to the tip of the chin. You got some people that just don't have a neck. Some people don't have a chin. There's some medical condition, people's chin just drop off. Those people can be hard intubations. And you want 2 fingers from the right under your chin to your hyoid bone. Most people can usually get 2 fingers right there. Not a big deal. So 3-3-2 rule is a good assessment too. And now when you're in the grocery store, Walmart, you're going to start looking at people like, damn, we want to intubate either. Or there'll be an easy intubation. So things to look at, and when we hop up in the back of them, it's sort of, oh man, this is going to suck. And then, you know, some people are pretty good. And like I say, even if they look good, they may not be. But most of the time, the big ones are the worst ones. We use the mnemonic lemon a lot. So look externally. Did they have a beard? They have a facial trauma? You know, a lot of bikers and stuff like that have these huge beards, huge goatees. You can't get a good mask seal if if we have a failed airway. We have to bag these people. What kind of teeth do they have? Do they have false teeth? Do they not have any teeth? Sometimes having no teeth is a bad thing too, because everything just falls back in their mouth, and it's hard to scoop that tongue out of the way and get to it. So look and see if they have false teeth. If they don't have any teeth, they have false teeth, you can take them out, because sometimes once you get in there, those things start falling every way. So they have a partial. The E is the evaluation 3-3-2 rule. M is malempathy that we talked about. O is obstruction. Do they have a tumor? Do they have anything weird? Do they have something going on in the throat or neck? Do they have some sort of trauma where they have a hematoma there? Abscesses. Do they have epiglottitis? If it's kids or things like that, or have hematomas or trauma. Just take all that stuff into account. Like say, if they're breathing good or breathing okay, and we know or think there'll be a difficult airway, and we think we can make it to the hospital, go ahead and, you don't have to RSI everybody just because they have an indication for it. It's kind of what you feel like they need. But if you don't think it's going to be an easy airway, and you can hold off on that intubation, do it. That's just a bad feeling not being able to get somebody intubated. Neck mobility, chin to chest, trauma, they're not going to be able to do it, of course. Don't throw their head back. Like I say, if you go to the OR, y'all still do clinicals in the OR? Take it away. Those are great because you can just jump from room to room and intubate people. I wish they took that away. So when you hang out with an anesthesiologist, whatever, if you have somebody in surgery, that's what they're going to do. They're going to go around, put your chin to your chest, put your head back. Again, this is not a difficult airway class, but if you can throw that head back, it kind of lines everything up a little bit better. Trauma, contraindicated. It's a lot harder because you kind of have to start looking up. But if you can throw a head back and drop it off the stretcher, it lines everything up. If it's kids, you can put towels under the shoulders to line everything up. So the more you can move the head, the better. So people you want to intubate, strokes, seizures, non-trauma cases, get your partner and just crank that head back as far as it'll go. So literally their back is almost arched off the stretcher. And that helps you line everything up a little bit. It may be cheating, but hey, at least you'll get airway. Don't be afraid to cheat. It's fair game. Trauma's a little bit different. You may see us take the collar off a little bit, and we may have to move the head a little bit. We usually try not to, or we're not supposed to, but you may see us give us some crack pressure or something like that. So we'll use the top of the collar and get somebody to hold Sound cool, down. Pop that collar. 332 rule again. The 5 P's of RSI. Preparation is the most important. First thing you do, if you know you're going to intubate somebody, they probably got a non-rebreather on anyway, just crank it. Not 15 liters, I'm talking about flush. 25 liters, whatever, it'll give them. I'm talking wide open. They're still breathing okay, and we'll show you why in just a second. So I think pre-oxygenation should be first. So that's like the first thing you want to do is crank that O2 wide open, as long as you're breathing. Preparation, you want all your stuff out, because if it's out of arm's reach, it might as well be in the next room. You don't have anybody get it to you. You want your laryngoscope, you want the right blade, you want your ET tube with your syringe on, you want suction, stick it under the head of the stretcher, stick it under their head, stick it under the backboard. You want that. You want your bougie ET tube, what else I'm missing? You want your tube security device, whatever you want to call it. Commercial ones work really good. That's what we use. I never had good luck with tape and stuff like that, because it's just aggravating to get under somebody's head and wrap it around and blood and it doesn't stick. So those little tube security devices with the screw on it, everybody seen those? Mm-hmm. Yeah, they usually work pretty good. Pre-treatment in the state, they've been back and forth. It's almost like snake bites and everything else. What are you doing this week? Oh, we're putting a tourniquet on. Next week we won't put a tourniquet on. Pre-treatment, talking about lidocaine and atropine, and they recommended, and then they took it away, but the state protocols, it says lidocaine for head injury patients. This causes when you're intubating and keeps some ICP down. But then they come back and say, oh, we don't have any hardcore proof that it did do that. But atropine in kids, atropine in adults that have a low heart rate. So as you get a little vagal response, you put that laryngoscope in their mouth. So make sure you pre-treat them with lidocaine or whatever. Paralyze them. We'll get to that. And placement, you want to verify it. And this is somebody else's words there. And if you don't plan, don't have your suction ready, it's over there and it's not hooked up. I mean, you're in there, and each time you take a look or introduce a laryngoscope in somebody's mouth, there's a chart or a curve that for each attempt your success rate drops. So it's bad. The more times you go in there and try to put a tube in there, you will have a greater chance of failing or not getting that airway. So you start getting blood in there, because some people, you're starting to tear stuff on them, and you go from a clean, nice, pretty airway to blood and stuff like that. So if you don't have suction in there, and you got to pull out and do that and bag, so have everything right there with you. Make sure you have your BVM. Have it hooked up. Most ambulances have a couple of O2 ports, so make sure you have one hooked up to that. Laryngoscope blades of various sizes, and when you learn a little bit more about intubation, if you haven't already or get experience, most everybody takes a Mac 3 or a Mac 4 unless it's a few. So most everybody go with a Mac 4. I don't use the straight blades a lot, just never have. I do it with a Mac, but maybe cheating a little bit too, but it works. Here's your semi-rigid style left there. I think that's what they're calling. Rescue airway device, King Airway or LMA. And I got these. That's a King tube. Y'all can pass that around if you want. We call it a backup airway or a blind insertion device, a BID. And basically all you do is go in one side of the mouth. Put this down. Just go in one side of the mouth, inflate that, put 60 milliliters of air in there, and you start bagging them. And you pull back till you get breath sounds or CO2. But usually the teeth will line up over there. So that's a big one. I think it's like 100. It's the biggest one we got. I forgot how many kilos it goes up to. So a 5 is, it's greater than 6 feet or tall. So I just want to pass that around over. So have one of those. We keep those in there. They say once you take somebody's respiratory drive away from them, you're going to have to do something for them. This is called an air cue. It's an LMA, if y'all heard those. We use a lot of those in surgery sometimes. The company that sells these things say it's an intubating LMA, but really not had good luck with it. If you see, a lot of LMAs have the little fenestrations over the opening where the air comes out. This one does it. So I haven't opened this one yet because these things are fairly expensive and that one's expired. But they say if you put this thing in, and then if you're getting good ventilations, you can run this bougie down there, and I forgot the percentage rate, but they say, 95% of the time it's going to come out of that hole and it's going to go right into the trachea. Not the case. So then you don't know if you're in the trachea or not. You pull that out, and you're not in the trachea, then you have to stick it back in, so it's a mess. So once we usually put these in, that are in, we leave them until we get to the hospital. And that's the same way. Kind of stick it in there, maneuver a little bit. You can add air to it if you want to, but usually you don't have to. You just kind of manipulate a little bit until you start getting breath sounds and CO2. Surgical airway equipment, we keep that. We can do a needle cric if we have to, or we got the surgical cric stuff. Again, not what we want to have to do. Any questions so far? Always make sure the patient's on the cardiac, blood pressure, pulse ox, because you want to watch that stuff, man. If they're not on the monitor and you're in there digging around looking and they're getting, bradycardia because you're giving them a vagal response, or the blood pressure drops, or they're starting to get hypoxia because they haven't breathed in a couple minutes, you need to, make sure that you have somebody watching the monitor. So this RSI needs to have at least a couple people there that know what they're doing. I mean, not knocking, say volunteer or something like that. They'll be watching you. They're not going to be, and you're not going to be listening to that monitor go beep, beep, and then it starts getting slower and slower. Bad sign also. So make sure you have all that stuff hooked up to them. You need a baseline vitals before you start. Dairy, not that big of a deal, but you really need to watch the heart rate and the pulse ox at a minimum. Blood pressure's great. That way you know what you started with. If you give them some Versed or something toward the end, that's going to drop their blood pressure. But damn, is that because of the Versed or because of hypovolemic? So we always need a baseline before we start. And for charting purposes, always include initial. That's the first thing you want to do. We hop in there, we'll put them on our monitor because we got CO2 and most everybody does now, but we're going to leave them on our monitor, so we'll go ahead and hook them up. Hit the blood pressure button. And most monitors, if you use Zols, you got to turn that end-tidal CO2 on and let it warm up a little bit. So we'll go ahead and do that and throw it down to auto zero itself. Because once you hook it up, it takes about a minute to warm up. And that's not the time that you want to be waiting to see if your tube's in place while that thing's warming up. Check IV sites for patency. Again, EMS, you guys have been fighting these people. You want to make sure these IV lines flush well and make sure they aspirate blood, because that's the last thing you want to do is get ready to push something and your IV's no good. So then it goes in the arm or wherever, you're getting ready to intubate, IV's not good, so then you got to stop what you're doing, start another IV, draw up your meds again, so you just wasted a few minutes there. So always check your IVs, and more than one is great. I mean, one will work, but more than one is great. Go ahead, and we got 2 crews on the helicopter, so it's a little easier. Kind of the medic will be up there at the head, getting all their stuff ready, intubation stuff. The nurse will be drawing up the meds, getting that ready. We don't really verify the dose with our partner. You really can't over-paralyze someone. Accommodate's really not going to hurt them like too many things. But it's always good. I keep a little note card. We got everything listed in there. If you weigh so many kilograms, you get this much. I mean, most of the time you can do it in your head, but kids and stuff like that are a little more trickier. End-tidal CO2, we talked about that. The pre-oxygenate, they say 5 minutes of 100% is best, and it is. So, like I say, the first thing I do, if I get a report on the radio and I know we're going to intubate this patient, if they're on a non-rebreather, just crank that oxygen wide open. To knock out that nitrogen in their lungs, the reservoir. So that gives you a couple minutes of O2 in their blood. So they say 3 to 5 minutes. So that's a lot of time to be intubating somebody. And usually after about 30 seconds to a minute of laryngoscope in their mouth, you're going to pull out and bag them for a little while anyway. And we'll get to this in a second. We'll skip over it. But you don't want to bag these people a lot unless you have to, because when you bag somebody, where does the air go? Yeah, some goes to the stomach, some goes to the lungs. So you fill those that stomach up with air, then what happens? They puke. If you don't have suction ready, where does it go? Right down the lungs. So we try not to bag anybody. Like I say, if they're holding their sats, that's fine. If they're not and they need assistance, don't be afraid to assist them. But you want to avoid it if you can. If you do have to bag them, you can use cric pressure, and that does help. But it honestly takes a hand to know what it's doing. I mean, if I'm on your truck and you're helping me do something, and then somebody else is doing something else, you kind of have to have like a third or fourth person there that knows what they're doing to hold pressure, crank pressure down. So that's good to do, and if you got one there, then you can't be doing something with your other hand. So if you got the people do that while you're bagging them, it's not a big deal, but it helps prevent vomiting. And we've already talked about this stuff. These are your pre-treatments. Lidocaine for head injuries to reduce the ICP during intubation. And that's controversial. The state protocols say it. And if you want to get up there and slam 100 milligrams in, 75 milligrams in, we can say that we gave it, we say we considered it. It's probably not going to hurt them either way, but is it going to help them? You know, who knows? Well, like I say, we used to do it almost every intubation, but we don't anymore. We don't even carry it in our little leg pouch anymore. Atropine 0.02 per kilogram, to a max of 1 milligram. So that is a lot of atropine. So it didn't take a whole lot. You make sure you give it to kids less than 12 because they're going to tend to vagal down a little bit more and become bradycardic. And it says give to patients requiring a second dose of subs. We hope we don't have to give them a second dose of subs. If you're doing that and you've been in there a little while, then they probably are vagaling down. All patients to be adequately sedated when possible, and we'll get to the drugs in just a second. I think the state's got fentanyl and Versed coming up. Is that right? For the new protocols. Versed better, but if they're a trauma patient, a hypovolemic, some sort of head injury, and they got a low blood pressure, you want to stay away from Versed because it's going to drop them like crazy. Now, if they're a stroke, they've got a high blood pressure, then Versed is going to be good for them because it's going to get them down. But be careful with strokes. You don't want to take too much blood pressure away with a bleed. All this RSI, you're going to have a huge chart when you RSI somebody, and you should. So, yes?
Will you tell them the importance? If you back up that one slide, it said that all patients that are going to be paralyzed need to be sedated. We tell them the importance of sedation.
Yeah, I'm going to get to that. It's kind of a little earlier than it should be. It will come in the drugs. So our Tomidate, they said Amidate, A-M-I-D-A-T, Tomidate. I don't know why they call it that. It's almost like a date rape drug. It's very short acting. Not that I've ever considered it. But it's very, ketamine's the good one, then we'll get to that in a second. It's very short acting. We're using ER a good bit to reset a shoulder or reset a hip. Man, you give them that Atomidate and they're sitting there talking to you and they'll just start snoring. And they're breathing, they're snoring. You can't wake them up for nothing. Pull that hip back in, pull that shoulder back in. About 5 minutes they'll wake up. Have y'all started yet? But if you do a Tomidate, we do keep a BVM at the bedside. We usually throw them on some high flow, or not high flow, but 4 to 6 liters per minute with a nasal cannula just to wash, especially old people that have sleep apnea and stuff like that. Like I say, about 3 minutes is all it's good for. It's very short acting. Again, document. Remind me toward the end of the class, we'll talk a little bit about documenting. It's not a narcotic. It's a non-barbiturate. It's a hypnotic. I've never tried it. Maybe I need to try a small dose of it. Blah, blah, blah. Sleep is produced within 1 minute and lasts less than 10. Usually you get about 3 to 5 minutes out of it. This is your ketamine. Tomidate was on back order. All the drugs were on back order about a year or so ago. We had to switch to ketamine. We really didn't have good results with it. Ketamine's a good drug in kids and ORs and stuff like that, where you can keep people NPO, things like that. But the dose, let me go back to the dose. So 0.3 milligrams per kilogram. So almost everybody would get a 20 milligram, no matter what. Somebody, it's a little bit bigger, they may go ahead and give them 30. It comes in, either come in 20 milligrams or 40 milligrams. So most of the time we'll just throw up a whole bottle and we'll give 20 milligrams of it. And that'll usually do the trick. Now somebody bigger, 250 pounds, we'll go ahead and give them a 30 milligram dose, which that's what they should get anyway. But most of the time 20 milligrams will do the trick. The ketamine, getting back to it, we just didn't have good results with that. I'm pretty sure it's in the protocols too. We didn't have good results with it. It doesn't do what a Tomidate does. So this is your good date rape drug right here, vitamin K. People sell it on the street.
Horse tranquilizer, isn't it?
It may be. They probably do use it in horses.
Pretty sure it is.
So, we used to sedate kids with it a lot when I worked in Atlanta. And it wouldn't really put them to sleep like a Tomidate does. It would knock them out. They would be there with their eyes open. They may look around a little bit or have some nystagmus or something like that. But, I mean, it totally dissociates everything. When those kids would come out of that drunk or that stupor, they would be cussing. They would be doing all kinds of stuff. And the parents was like, wow, where's my kid? So, does work, not as good as the Tomidate. It's going to make them slobber and drool and everything else, and that's not what we need when we're doing an airway. So when we did this in kids, we would give them some Robenal, which kind of is almost like atropine. It dried them up. So we'd give them Robenal about 30 minutes ahead, then give them some ketamine. This ketamine is going to make them have secretions and stuff like that. The Robenal will dry them up. You're going to get a noted increase in blood pressure when you give them the ketamine. If they need an airway and they got a stroke and their blood pressure's already 200 or 300, then I guess you got to do what you got to do. But just know that if you got a decent pressure, you give them ketamine, it's going to bump it up. Here's your sucks. Good stuff. I've never, well, take that back. We had a flight this weekend that they had to redose the guy with sucks. Just cause he didn't take it to him for some reason. So I won't get into the mechanism with it, but it usually starts in about 30 to 60 seconds, and it lasts about 2 to 3 minutes. So that's right there with your Tomidate. So it takes a little longer than that. Tomidate is real fast acting. So what we usually do, we'll push the sucks first, and then the Tomidate. And again, you don't want somebody paralyzed that knows what's going on, so they need to get that Tomidate pretty soon. It just seems to take that sucks a little bit longer to start working. I mean, it really doesn't matter which order you push them in, so sometimes they're right there around the same. Yeah, you may get up to, it says 2 to 3 minutes, gradually up to 10. I've never seen it last for that long. Some people do. If they have a decreased mental status anyway, you may not see them starting to wake up a little bit from it. You'll learn your lesson when you paralyze somebody with sucks and you intubate them and you're all happy, whatever. All right, let's get them to the helicopter. You get them to the helicopter, and by the time you move them back and forth, they're starting to wake up. So you're going to need to be reaching for something else. We'll get to that next drug in a second. So it doesn't last long. And it's usually 1 to 1.5 milligrams per kilogram on adults. So 70 to 100, something like that, will work. But take that back. So double. It's about 150. If you have people that have been on drugs and meth and stuff like that, they tend to eat through these paralytics for some reason. Their metabolism is so high, they'll eat through these paralytics. So you may see the sucks may not work. You may have to give them a little more. You may have to double the dose to 1.5 milligrams to 2 milligrams on these people that we suspect are on drugs. Because not only it doesn't work well for them, it doesn't last as long. So we start giving the rock or the Zimuron, who we'll talk about in a second. You may see it, instead of lasting 30 minutes, it may last 15 minutes. You're like, man, why are they waking up? Why aren't they waking up? Or people that are on narcotics and different drugs and have a history of it, they just tend to eat through this stuff. Kids' metabolisms are high too, so increase your dose to at least 0.5 or another whole milligram for them because they'll eat through it. Can over-paralyze someone, so don't worry about that. Sucks should be refrigerated. We have a little refrigerator of it. It's good for about 30 days from the time you pull it out. So what we'll do, we'll take a Sharpie and we'll write on it and keep it out for 30 days. And yeah, maybe someone's been left out 40 or 50 days. It still works, but you don't want to get in a situation and be like, uh-oh, my sucks didn't last because I didn't work because I left it out of the fridge too many days. Sucks is cheap. Throw it away, get you some more. We carry a little leg bag, so that's what we put our sucks in. It usually comes in like 200 milligram vials, so one vial is usually enough to do a patient pretty good. This is contraindications to sucks. When you give them that sucks, it causes the release of all that potassium in the blood or the cells to come out to the blood. So if they've already got a hyperkalemia, you don't want to do that. If they've had some sort of lobe injury, nothing to do with hyperkalemia, but you don't want to give them the potassium for that. I think it causes an increased intraocular pressure. So it is contraindication. You may want to ask your doctor. I don't know if somebody's got something in their eye, they may need an airway as well. So there is a backup for this. Crush, burns, rhabdo, extremity fractures, greater than 24 hours. I mean, unless somebody's been laying in a car all night or under a car or under a tractor for a couple of days, or not a couple of days, but a day or something like that, you really want to take that into account because these people have a lot of, once you pull that stuff off of them, they'll have rhabdo, they'll probably have some potassium in it, and it'll definitely cause a hypokalemia in them. So burns are the same way. Spinal cord injuries over 48 hours old. Never really seen that, but again, your people and the people we fly are not going to have these. It's usually when it happens, we usually know about it. And sucks is contraindication. I've never seen a sucks contraindication in the field on our end of it anyway. Malignant hypothermia, most of the time you're not going to know that. This is something that they will know if they've had a surgery and they've been intubated before and they have a malignant hypothermia. So, I mean, if the family gets up there and tells you, hey, they got malignant hypothermia, you're not going to paralyze them, are you? But, oh, man, they need to do something else. Muscular dystrophy, things like that. It says use caution in them, but, most of the time, how are you going to know? Rocky Romeo is your next dose there. So you get 0.6 to 1.2. I suck at math, went to public schools. I always do 1 milligram of rock or Zimiron. But keep in mind, we'll get to Zimiron in just a second, or we'll call it Zimiron rocks, all the same thing. Lasts 30 minutes. So instead of this 5-minute sucks you got, and you take somebody's airway away, you're going to be bagging them for 30 minutes, or until you get a tube. So I've never done that, knock on wood, never seen a contraindication to it, but rock lasts a lot longer. Got rock on here. Right. Rock would be, after we intubate somebody, it depends on where we're going, whether we give them this rock or the vecuronium. You may hear it called Norcuron, you may hear that called Zimiron, they're the same thing. If we're going to Columbus or somewhere, we may just give them a rock. The good thing about rock or Zimiron is it's already in a liquid form. It's easy to draw it up, give it to them. Really not any contraindications to it. Blah, blah, blah. Usually takes, I've seen it, it doesn't usually take 3 minutes to totally paralyze them. When we give it, most of the time they're already paralyzed. So we go ahead and give it and we get 30 minutes out of it. So the VAC, on the other hand, it's in a powder form, so you have to reconstitute it, take a flush, slam it in there. It comes in 10 milligram vials. It's a powder. You put 10 milliliters of saline in it. You got 10 milligrams, and they get 0.01 per milligram, so a 100 kilogram patient just take the whole vial. So we usually round that up to. You really can't over paralyze somebody. And it usually 2 to 3 minutes it takes to work, and it does last 45 minutes to an hour. Now, somebody that had a drug problem or on meth or something like that, maybe VAC would be a good choice for them because it's going to take them a little longer to eat through it. It tends to be a little bit stronger. So VAC's good. If we got a long transport time, we will do VAC. But most of the time, people just reach for the rock and do it. The laser doesn't work too good. This is the main thing right here. Before you go up and start slamming anybody with these long-acting paralytics, you want to make sure that ET tube is in there. You want to verify it by auscultation, end-tidal CO2, chest X-ray if you can. Get somebody else to listen. Because that's the last thing you want to do is paralyze somebody with these long-acting paralytics and they not have an airway. That's bad stuff right there. Anybody know why we avoid long-acting paralytics with seizure activity?
You wouldn't be able to tell they're having a seizure.
That's right. So you wouldn't. Somebody smoking in here? Let's keep looking around. Am I that boring or? So anyway, yeah, you're right. You don't know if these people are having a seizure. So how are you going to treat it if you give them Ativan or whatever? So they may not be twitching and stuff like that. So just FYI.
Well, it doesn't matter if they're having a seizure.
It really doesn't, but if they're having frequent seizures, they have to come out of it, we want to treat them something, some sort of, I can't think of the name of it now, but, you don't have to give them the Ativan or whatever for it, because they're having a seizure to stop it, but you want to kind of stop the seizure, you know, the electrical activity in the brain. That's what you want to stop. So when we get ready to intubate somebody, do our meds, get everything pushed in there. Once you push that stuff, you go ahead and get your partner to do some crike pressure. That usually helps out. Everybody done that before? Or done it? There was a mnemonic called BURP, B-U-R-P. It's pull it down, back, up, right, pressure. So usually push that down. You may have to tell your partner, let off a little bit or give me a little bit more. And if they know what they're doing, they can manipulate that around a little bit into your view. So if you think about it, you go to the patient's right, and that's the side that you come in from. So hopefully they'll push those vocal cords into your view by going to the patient's right. This is what you want to see. That's what you don't want to see. And a lot of times that's a laryngeal spasm right there closed. And a lot of times those sucks will make it relax. Now, sucks is a skeletal muscle. Somebody smoking out there, Nick? Maybe the janitor's up there. So, if you are able to get a view of the vocal cords and they got that, give them just a second. Then hopefully those things will open up. A lot of times, and it works the other way too. If you hit them with that bougie, they may open up. Sometimes if you hit them with that bougie, they'll close up like that. And always, if you see those things go through the vocal cords, that's great. And a lot of times you may not see it. And we'll show you how to verify that. But if you can see it, that's great. You want a good view of it to make sure where it's going. So once you do that, inflate the cuff if you have a cuffed ET tube. And all these things are great things to chart. If you want to cover your butt like crazy on an RSI chart, you don't want these people to, you don't want to dislodge your tube en route. You don't want these people to have a noxious brain injury because, they said, you didn't intubate me right, or you didn't intubate my family right. Never mind, they weren't breathing the 5 or 10 minutes before you got there because they were clenched down. So direct visualization, you want to chart that. Say, I saw the tube go through the vocal cords. We didn't have any gurgling over the epigastrium. Had bilateral breath sounds. We had a positive end-tidal CO2 on our monitor. Fogging in the tube is not as reliable, but it is reliable. I wouldn't use it for a definitive tube placement. Chest rise and fall is great, especially pulse ox. If the pulse ox starts to go up. End-tidal CO2 breath sounds are the most important. A lot of times the weird traumas and like diaphragmatic hernias and injuries and stuff like that, you may not get breath sounds. You may not get breath sounds because they have a pneumothorax, or you may get gurgling in the chest. So that's few and far between them. Again, secure that tube good. Make sure it's tight. I mean, you don't care if it's scrunched down in the patient's face and pulling them out. We don't want any play, because if you think about it, you may not have an inch or two. So you move that around a little bit. You get somebody not paying attention while you move them, the tube's out. And it didn't take that much. And again, got these patients paralyzed for 30 minutes now. Crap. I mean, yeah, we may get that airway again, but then we may not. And if you got anybody work for a service? I need to work for a service. Anybody got work for a service? Y'all got an end-tidal CO2 already? Isn't it like standard now? Make sure your monitor print the waveform on the strip. Yes. Yeah. Always attach that, make a copy of that and stick it on the chart, scan it in, whatever you got to do. Because that's the last thing you want to do in 5 years. You don't remember this call coming back to, you killed so-and-so because you didn't get the tube in there. Well, there's a waveform. I did it. Hospital did it. ER did it. So after we intubate them, remember, time of date, 3 to 5 minutes. Sucks, 3 to 5 minutes. And they're fighting us before, and we only knocked them out for 3 to 5 minutes. So what are they going to do? Now they're waking up and they got something in their throat and they can't holler. So the first thing they're going to do is going to grab that. So as soon as we got that tube verified, this is what we want to do. Give them a long-acting paralytic. But first, you ever heard the stories in the OR, I was put to sleep and I could feel everything. That's what these paralytics do. They don't do anything to your mind. They do everything to your body. So to paralyze you right now, you can remember everything I was saying, but it would suck. Because you couldn't move, you couldn't do anything but just lay there. So that's what happens. And paralytics have no effect over what the brain does. So they work, at the the muscle level only. So we give them some Versed, midazolam, too, so they can't remember it. It's like a hypnotic. And it's 0.05 to 0.1 milligram, 3 to 5. But that's a little dose. Usually you can take somebody, if their blood pressure's good and they're not a little low grandma or whatever, they can handle 5 milligrams of Versed, no problem. But you may want to start around, kids. You could always use something else. You're starting to get around half milligram, 1, 2, 3, stuff like that. You don't want to give somebody too much Versed because it's going to kill their pressure. So keep that into account before you give them a big slam of Versed, especially if you push it fast. It should be given over a couple minutes anyway. But like it says, they're usually 2 to 4 milligrams IV. Give it over 30 seconds to a minute. You got a question?
On average, when you do RSI, how many drugs do you put?
We got sucks, you got etomidate, you got your post-intubation stuff, so either Versed or fentanyl, and then a longer acting paralytic. So about 5 or 6. But, you give your 2 initially, etomidate, sucks, intubate, then you go to your post-management. Where are we at? It's a good benzo. You could use Valium, I think, but I wouldn't want to. We used to use Ativan a lot, and we still do. We give them high doses of fentanyl. Now think about it. The only reason you don't give people a lot of morphine and stuff like that when they're awake is because you decrease their respiratory drive, and they do stop breathing on you, or their blood pressure drops. I mean, you can sedate people with technically whatever you wanted to if you had it, but these are the ones of choice: Ativan, Versed, fentanyl. Yeah, they will never remember that they got Versed. Probably never remember that they got intubated, even if they were wide awake. You get your hypotension with Versed, so use caution with that. Your long-acting paralytics, back 30 to 45 minutes, maybe an hour, maybe 40 to 60 minutes, but usually it's longer than 30. The rock is right about 30 minutes. So again, depends on your transport time, what you want to give. You can redose them a rock a time or two. It's just easier because it's already pre-mixed. Make sure you keep that end-tidal CO2 on every move, and especially during the chart. When you're doing your chart, you want to document move patient to wherever. Confirm tube place with end-tidal CO2, bilateral breath sounds, whatever, chest rise and fall. You want to cover your butt every time you move that patient and chart that we have good end-tidal CO2. We won't get into what their end-tidal CO2 should be, but usually not less than 35 to 45. You guys will learn that later on if you don't know it already. You can faster you bag them, the lower it's going to go. Usually when you intubate these people, the good thing about it, they haven't been breathing good for a couple minutes, and as soon as you put your end-tidal CO2 on, their CO2 is 50, unless you're at a hospital or something like that, and they've been bagging them for 50, 60 times a minute, and then their CO2's 15. I don't know, does anybody carry a band in here on the ambulance? Probably not. That's the gold standard, is to put them on the vent, but hey, if all you got to do is bag them, and bag them is fine. We used to bag people to the hospital. Even if it was here at Columbus, it's like, all right, we'll just bag them. But it takes a couple minutes to set up our vent. We got to hook the vent circuit up to it. It's got 3 little pressure lines that's got to go on it. Now the gold standard, that way they're getting, an adequate tidal volume. They're getting PEEP. They're getting, the right volume every time, the right rate. So now we've gotten to where they want us to put the vent on every intubated patient, no matter how short the flight is. The documentation, we've already talked about why we done it, why we chose RSI. Because even if we don't get this airway, and we had a good reason for it, at least we can say, this is why I done it, and it fits the protocols. So, if I screwed up, or not that I screwed up, but if we couldn't get it, some people you just can't intubate. You hear these stories at the OR that, you get anesthesiologists and CRNAs that intubate people every day that can't get these people intubated. So, just some people you can't intubate. So, but make sure that you cover your butt on why we chose the RSI. Get as much history and stuff you can. Remember, use your lemon rule. Look them over good. Get your vital signs before and after. We usually set our monitor, put it on cruise control, either 5-minute or 10-minute blood pressures, depending on where we're going. So that way you can watch it and make sure you keep an eye on that CO2. And I don't know which kind of CO2 you got. Usually the CO2 cords are shorter. Ours is called the, I forgot the name of it, it's a little orange tip, but it's like a plastic tube that hooks right to our monitor. Some of those olds have like the little seat that goes, clamps over the sensor, but those are usually shorter. So if you're moving that monitor way over there, you've got it down on the feet, be careful, don't pull that entire CO2 cord because you'll snatch that tube out. Chart your medication's good. And one thing they used to tear us up on, and they still do, and they'll tear you up on, is not giving an appropriate sedative after you intubate these people, or forgetting to give a sedative. That's just bad. These are the people that the stories you hear about that's going to tell you everything that you said while they were in the ambulance with you because you didn't sedate them. So just think about it. Would you want to be laying there with a tube in your mouth and not being able to move anything, and remember all of it? So make sure you give appropriate sedation and appropriate doses for it. Chart your size and depth of your ET2. The bigger the better. Used to, everybody says what, 7.5's the common size. I mean, first thing we pull out is usually an 8. Because depending on what's wrong with them, we get people that swallow teeth or swallow whatever, and they need a bronch or something like that later on. Well, these doctors don't like a little 7 ET2. Now, if that's all you can get, that's great. But the bigger the better. That way they can remove stuff, or they can bronch them if they need to with these size 8 ET tubes. I think 8.5 is about the biggest I've ever done. And also make sure you chart your depth. What's the general rule of the depth charting on the ET tubes? Anybody know? It should be 3 times the size of the ET tube where your centimeter should be. So if it's a size 8, the line should be around 24 at the teeth. If it's a size 7, it should be around 21 at the teeth. That way you always know. That's one of the first things we do is we'll look at that and we're like, okay, if it's a 21, we move them a couple times, we look again, it's at 17 now, uh-oh, might have been screwed up. Or we look back and we know it's at 21. That's just another way of saying we know that tube's in there, or at least it hasn't moved up. It may have come out and then went back in, but make sure you know what it's secured at. That's just one more thing, and document that. Because, if it's too deep, you'll do a right main stem. I'll say this while I forget about it. If you do use that bougie and you don't see that ET2 pass through the cords, but we got breath sounds or unilateral breath sounds, but we got CO2, so we're in the trachea, and we look at that and say we're on a size 8 ET tube, and instead of 24, we may be like 27. So pull up, bag, and pull up and bag. Get somebody to listen for you until you get bilateral breath sounds. A little bit at a time, because we know where that tube should be about right around 24. So if you ever go in and see somebody where the BBM connection is sticking that far out of the mouth, that tube's way too deep, something's wrong there. So we'll back that out a little bit until we hear breath sounds, a little bit at a time. If we don't ever get to 3, what time is it? We good? Oh, we got plenty of time. Only 2 more hours. Anybody got any questions so far? So if we don't get this tube, we need to remove the tube course and start using the BVM. Remember, they don't have an airway drive anymore. They're not breathing on their own. So bag them. Kind of fall back to your BLS airway stuff. You can do an OPA if you have to. You can keep that crack pressure down if you got a free hand to do it. That prevents some of the gastric distension. Use your burp maneuver, back upright pressure. I don't know what they're talking about really. Remedicate them as needed, because I guess you don't get it. You want another shot at it, then you might want to give them another dose of accommodating subs to try again. Let your partner try, and granted, I don't know how you're going to get experience if you never have experience with it, but usually somebody intubating, you want the most experienced intubator there. So I walked into a hospital one time. I'm not going to say it because it's close to around here, and we walk in, and the doctor says, "Who is the best intubator It's like, oh man. So we walk in this room, there's bloody ET2s, there's bloody blades, there's a video laryngoscope, a Godscope. It's all laying on the floor, and it's like crap. Those are bad. Those are the ones that you try so many times, and then your success rate just starts to go to the floor. And we never did get that guy. My partner was one of the best intubators that I've ever flown with. But I was like, oh man, when calls are bad, they're bad. I mean, it's just Murphy's Law. If it can happen, it will, and it stinks for everybody involved. You know, if you can't get it 2 or 3 attempts, then you probably should stop trying, because you know, think about it. You're in there 30 seconds. You're moving stuff around. You bag them a little bit. You go back in there. You're in there 30 seconds, 45 seconds. Another time, you're gonna have to redose them anyway. So you're starting to get close to your 35 minutes.
Just because you couldn't see, or just because it's...
Just because you can't see, and it may be blood, and it may be just big, or they just may be anterior. You just can't see anything, and it stinks. It's a bad feeling. We did a stroke up at Dadeville the other day, and she looked like she was going to be easy intubation, but I mean, she wasn't. It took me 2 attempts to do it, and anytime you put that laryngoscope in the mouth, that counts as an attempt. If we weren't recording, I'd say chart it any way you want to, but technically, anytime the laryngoscope goes into the mouth, that counts as an attempt. That's why you need to have everything right there ready. Have somebody handing you stuff. I mean, once you see those vocal cords, never take your eye off of them. You just grab. That's all you do is grab. Never take your eye off of them. Because you got it at a good spot. Once you drop it down, you may never see it again. So make sure you have your backups in place. The King and the LMA, the intubating LMA air cue, same thing. King tube. You pass it around. And they work. They're not as good as an ET2, but they will work. You can ventilate through them. And it's funny. I mean, you get to the hospital sometimes, and the first thing those doctors do, oh, I can intubate this person. And they wind up taking that LMA or that King tube and putting it right back in after they try a couple times. So, surgical cracks, needle cracks. If we can't, there's cannot intubate, cannot ventilate times, and those are bad. Those are the days you want to wear that extra deodorant because you'll be sweating. So consider those surgical cracks and those needle cracks. Blah, blah, blah. So, I don't know what happened to that guy. There's a little bitty, I don't know if that's some sort of stenosis or something right there. So I don't know how good you can see it from out here. But I'm not sure what happened to this guy, but he's got himself a trach, it looks like. That's a bad day. So, College of Anesthesiologists is causing failed intubation after 3 unsuccessful attempts in more than 10 minutes. That's a long time. It's going to seem like, it may seem like 5 minutes to you, but you look at your watch, like, dang, we've been here a long time. We need to hurry up and do something. It's good to have a partner. You're focused on getting that airway. You need to have your partner just go ahead and elbow and say, hey man, we need to go to the hospital, and let them sort it out. Again, I stole some of these slides, and they're kind of based on air medical stuff. So if we couldn't get an airway, and even your state protocols say if you can't get an airway, go to the closest ER no matter what. No matter if it's not a trauma center or what, go to the closest hospital. Doesn't mean there's going to be someone that's more skilled in intubation there than you are, but just do that. That covers your butt. Like I say, some people you just can't intubate. Then we have to do this. As soon as we have a failed airway, we have to call our medical director. She's gotten better about it, but she used to ream her butts when it first started, because actually it's her license too. It's going to be your medical director's license. You can't intubate these people. They want to know why, what happened. Get your educator involved if we need to do some remediation training or what you face, things like that. Be good to know. Everybody knows the dope mnemonic. This slide's tube, so make sure you verify your position. If it's got some mucus plug or something in it, if it's kinked or bent over, if they have a pneumothorax, or if you got equipment failure, you got a hole in your BBM, your vent tube has come off, things like that. So always make sure you watch that monitor for bradycardia, hypoxia, because it will happen. you know, if the patient's blood pressure goes up or SAT goes down or something like that. You really want to watch that monitor. Sometimes maybe they're analgesic or their Versed, their fentanyl, something to wear off. They'll be trucking along, and all of a sudden that blood pressure will be 200. The heart rate will be 150 where it was 120. And you got to start considering pain or something like that, discomfort. Give them another dose of Versed or Ativan or fentanyl, and you may see that start to trend down a little bit. So, most of the time we treat your patient, not the monitor. And this time you kind of have to treat your monitor a little bit too, because that's the only way that you know what's going on with your patient. Okay, any questions? Well, thank y'all for having me. Y'all need me here.
Today's EMN5 is going to be on RSI drugs. There's a lot of different options out there, and I just want to go through some of the basics. The 3 steps that you're going to go through when you're thinking about RSI are going to be pre-treatment, induction, and paralysis. A lot of the pre-treatment is more of an equipment setup. Make sure you use the SOAP knee as a good mnemonic to go through. And then you're also going to have some drugs included in pre-treatment as well. So drugs for pre-treatment include lidocaine and atropine. Lidocaine is 1 mg per kg and atropine is 0.2 mg per kg, either IV or in ET tube. First, for pre-treatment, you need to ask, do I even need to pre-treat? The 2 situations I like to consider are increased intracranial pressure, in which case you would use lidocaine, or is this a pediatric patient, in which case you might want to use atropine to prevent reflex bradycardia. If you have neither of these 2 situations, you don't need pre-treatment. For the induction step, your drugs include etomidate, ketamine, fentanyl, and midaz. I'm going to go through a couple situations for each of these. Your go-to is pretty much going to be etomidate. It's a very good drug to use. There's less drop in blood pressure and heart rate. Otherwise, ask yourself, is this an asthma patient? For asthma, most people like to use ketamine because it's a good bronchodilator and also maintains your respiratory drive. And then other options, you can always use fentanyl and midazolam. For paralysis, the drugs available usually in the ER are succinylcholine and rocuronium are your go-tos. They're both 1 mg per kg IV. Your go-to is really going to be succinylcholine in most situations. However, you can also ask yourself, is this a patient at risk for hyperkalemia, such as dialysis patients, burns, large crush injuries. In those patients, you might want to consider using rocuronium. And just a note here that there is a large difference in the duration of succinylcholine and roc. Roc has a much longer onset, almost up to a minute, so many times people consider giving the rocuronium before the induction so that everything actually starts at once. And it also has a much longer duration, up to about 30 minutes. So you want to intubate the patient, get all your equipment ready, and the nurse asks you, what do you want? And you're sitting there starting to panic. Just think, your go-to, etomidate, 0.3, and succinylcholine, 1. So 100 kilo person, you're going to be 30 and 100. That's always a good place to start. Then just review in your mind, is this a patient that would be one of our special situations? Is this an asthma patient? Substitute out ketamine for etomidate, and ketamine is 1 to 2 mg per kg, makes it easy. And then is this a hyperkalemia patient? In which case you might want to substitute rocuronium for the succinylcholine, and that's 1 mg per kg, like to keep it easy. And then the last question, do you need pre-treatment? Ask yourself, is this a PEDS patient? Is this someone who has increased intracranial pressure? If no, you can move on to your next step. So those are the RSI drug basics. I hope you learned something today in 5 minutes.
With us. So without further ado, let's bring up our first speaker, Dr. Scott Weingart, the man, the myth, the legend.
Thank you. Just some housekeeping. If you have questions, you want to send it right to our Twitter moderator, so use @ParamedicWiki. And if you hashtag it SmackUS, we will continue being the biggest trend in the United States, which I think maybe worldwide. Maybe Min could help with that. What we're going to talk about today is resequencing intubation. Oh, I feel like I'm being pranked. my. Okay, all right, let's start off with the case. Yes, 43-year-old male, SAT of 80% on non-rebreather, rolls up to the clavicles, severe respiratory distress, but the patient keeps ripping off the non-rebreather, trying to get out of bed, and shouting he can't breathe. That's our case. And this case fits perfectly into a mantra that I've been preaching for the past, I think, decade at this point, which is every time we pick up a laryngoscope, we are essentially being given a license to kill. And how we go about using it depends on how much we care about our patients. So this lecture is how to stop killing our patients in the peri-intubation. Now, my friend Bill Hinckley put forth our goals when intubating a patient, and he expressed it this way.